As we just said, restless leg syndrome is fairly common in teens. Again, is underdiagnosed and almost never treated by the family physician. Should it be diagnosed? Should it be treated? Is it an important cause of sleep disturbance?
Yeah. I think this is very important because the restless is the only way to diagnose is history, and that's why the family physicians are very important. Last few years, I have had patients who have not slept for 20 years because of this illness, which has been missed for 20 years. And when we diagnose them, give them a tablet, he comes back within a week's time and says, "This is the first time in life I haven't slept so comfortably." So don't miss this condition. If you do it, it's probably very, a great person is going to be very grateful that you have diagnosed it. And in these minor forms which we will not treat, everybody can have little restless while sitting in the audience now and keep on moving a leg. So to that extent, it's not so common. But when it goes to the extent that a person has sleep disturbance, he gets intense desire to move the limbs to the extent that they get up and walk in this probably in the night and then go back to sleep and they're comfortable for a few minutes, again they get back. So if you go to that extent, the pathophysiology of this disease is still not understood. Is family history positive, and one can confirm it by doing a small assay of the blood, that is ferritin. The low ferritin is associated with restless syndrome. Of course, restless syndrome like condition can occur in many other differential diagnoses. The person with peripheral neuropathy or diabetes, small neuropathy also can have. The person with renal failure can also have. So there are other conditions, but the familial idiopathic restless syndrome diagnosis is basically based on history. There is usually a family history is positive, and if you treat them with dopamine agonists with a small dose, they get almost complete relief. The treatment, of course, is lifelong. You cannot stop it. As soon as it stops, it probably is going to recur. The drugs which we use is, of course, the non-ergot DA agonist. Because ergot DA agonist, as you know, has potential side effect, and it can lead to valvular problems and all that. So this is why either pramipexole or propinerol is the drug of choice, and you give only small dose at bedtime and it works well.
Common condition seen by family physicians is Bell's palsy. Bell's palsy, we know that there are two therapeutic things that we try. One is acyclovir tried and one is steroids that are tried. Which one of these two you use, or you use both?
I think I would be dishonest in saying that I use both, but the recent trials have shown that adding antiviral does not help at all. The steroids have been shown to prove. There are reports about 2 years ago that if you do a collection of CSF and do the HSV-PCR is positive, almost 70% of patients with Bell's palsy, and on the basis of that we had started using acyclovir. But the last trial, which is just published in 2009, has shown that addition of acyclovir did not matter at all as far as outcome is concerned. Steroids have been shown to be helpful, so high-dose steroid in a short span of about 8 to 10 days is definitely recommended, but I use both at the moment.
Okay. B12 deficiency is a common deficiency seen in the population, especially vegetarian, and has certain neuropsychiatric manifestations. Is B12 deficiency as a cause of neuropsychiatric problems overdiagnosed, or is it an important issue?
No, I think it's certainly an important issue. I think it's not a question of. I think many people, one of the common problem we face is about 70 or 60-50-year-old person, gentleman, talking who is pure vegetarian and talks of memory impairment, and you take that B12 comes low, you give them some B12 injectable and they all improve. So there is that. But in addition to, you can have pure presentations of dementia or subaqueous dementia due to B12 deficiency without any evidence of subaqueous combined degeneration or peripheral neuropathy. Because our standard teaching is that B12 you have subaqueous combined degeneration associated with mild cognitive impairment or memory impairment. But it's not necessarily true.
Dementia, the standard.
You can have what we call as leukoencephalopathy presentation of B12 deficiency. They present with gait disturbance. They have hardly any peripheral neuropathy, hardly any peripheral findings, and they are slow cognitively, like a subcortical dementia-like presentation. It's not uncommon at all. They have very high LDH, they may have LCD high, but the B12 is low, and they're completely reversible in therapy, and MRI shows vital changes. Now we can have people without MRI changes also presenting with just dementia or neuropsychiatric complication. So I think the workup of dementia, as we say right now, the bigger and thyroid is probably every patient must undergo.
Correctable causes of dementia, B12 hypothyroidism are important causes. Any other important causes of correctable dementia?
I think the reversible dementia, the two important, of course, which I have mentioned is B12 deficiency or nutritional deficiency, B1 deficiency also, particularly the history of ethanol use, and thyroid hypothyroidism. The other chronic infections, chronic meningitis in our population sometimes represents subacute dementia. And the third group is the structural lesions of the brain, subcutaneous hematoma can present subacute dementia. And non-operational hydrocephalus is one entity where you have gait disturbance, speech disturbance, and right forgetfulness as a presentation. And you do the MRI or CT and you find that the ventricles are large, disproportionate to the cortical ventricle, and then you can prove the diagnosis by CSF test and offer diagnosis and surgery, and they can improve.
Okay. The last question on the symptomatic therapy of painful neuropathy. This is common to diabetes also. Diabetic peripheral neuropathy often is very symptomatic, and we use drugs for painful neuropathy. What is your drug of choice for painful neuropathy? Amitriptyline, gabapentin, pregabalin, duloxetine?
I think it's probably not every patient will respond to your first line of therapy, so you'll have to follow a step-like approach. So the first drug which I generally start is a combination therapy of nortriptyline. I prefer nortriptyline to amitriptyline because lesser anticholinergic side effect, along with gabapentin. So at single dose at night both, and many of patients will respond to these. These dose of both can be increased gradually. You can start nortriptyline 25 mg at night and gradually bring it down to about 75 mg if it tolerates. And similarly, gabapentin start with 300 at bedtime and go up to 900 or so. So that's the first approach. If this doesn't work, then of course I go to pregabalin and duloxetine combination. Rarely we can still continue to use the older drugs, particularly carbamazepine, then the best of all. I don't use it as a first choice, but I do keep as a reserve. And something which I have found useful, of course, is not a drug which you should use on a long-term basis, is use of pimozide. In this neurologic pain, pimozide really works. Previously we used to use largactil or chlorpromazine, which is no longer being used. Instead of that, if you use pimozide for a buying time, till these drug doses can be built up, it also really helps them. And a small dose of 2 mg at bedtime gives a good relief. And duloxetine is a good drug, and pregabalin also is a very good drug, but that's my third probably choice.
Okay, that brings me to the end of my question set, but the rapid fire thing remains.